Hey, hello. Welcome to UW TelePain. It's, I think, just after 12 noon. I'm Jim Robinson, sitting in for David Calvin today. And so I think people are gradually making their way in. And so I'm also the speaker today. So I'm going to jump right into my talk, which is on functional assessment and pain. And there's quite an irony here. When I was a resident, the person who taught me the most was Dr. Walter Stoloff, who's here today. And last week, Dr. Stoloff gave me a copy of a chapter he has written on the way of assessing functional impairment and disability in patients with a variety of chronic medical problems. And it's an extremely detailed and extremely useful paper. So what I'm trying to do is get this scanned and sent out to all of you. What I'm going to do is really, relatively speaking, a kind of superficial run-through of functional assessment in patients with pain problems. As you say, I strongly recommend that you read the chapter from Dr. Stoloff when it comes, because it gives you a much more fine-grained way of assessing functional limitations and using those functional limitations as a way of orchestrating a treatment program. Just as a sort of aside on this, I don't know if any of you have ever seen discharge summaries from inpatient rehabilitation units, at least at the University of Washington, and you look at the problem list and there are about 25 problems. And you say, how could that be? And the reason is that what we learned to do was to identify the various functional deficits that a person had. So you have a person with T8 paraplegia, fine, that's a diagnosis. But then they have bowel and bladder impairment, they have possible skin safety issues, they have inability to ambulate but need to develop wheelchair skills, there are psychosocial issues. So the point is, what we learned in rehab was to identify multiple deficits that are related to the diagnosis and try to address those in our management. It's an extremely challenging and time-consuming task to do, but it's worthwhile. Now, what I'm going to do is, as I say, a much more superficial analysis of and talk about functional assessment and pain. It's not going to be in as fine-grained as the chapter you will be getting. Okay, so first, diagnosis versus functional impairment assessment. Diagnosis usually gives you a qualitative understanding. So a person may have a C7 radiculopathy. They may have a fracture of the humeral head, whatever. A diagnosis says qualitatively what is wrong, and I think very importantly, identifies the body part or pathophysiology involved if we're, in certain diagnoses, and it may well suggest treatment approaches. If a person has a comminuted fracture, it suggests orthopedic management. If they have a C7 radiculopathy, they may be a candidate for epidural steroid injection. So they're certainly important. Diagnosis is not trivial at all. But I would argue that diagnosis is often arbitrary. It's difficult and often arbitrary in chronic pain patients. I had a patient come in today to see me whose mother accompanied him and basically said, why doesn't my son have a diagnosis? And he has pain over his entire body. And what I pointed out, and they were willing to accept, they're more accepting than some folks, that when we make diagnoses in medicine, virtually all of them are basically made within the conceptual model that there is tissue injury of some kind, and that produces pain in a relatively uncomplicated way. The nervous system does just what it's supposed to do, registers that there is something wrong in some tissue of the body, and the way we fix that or address that is to fix that injured part. I would say that in our chronic pain patients, that model simply often doesn't work. Probably what's going on is some alteration in nervous system functioning for which we don't have diagnoses as far as I'm concerned. We can make them up, but we don't really have them. So one problem with diagnosis is that it is often arbitrary and stretched when we apply to our chronic pain patients. Another issue is that the diagnosis doesn't tell you anything, or very little, in our pain patients about how impaired the person will be. And I give the examples of Joe Montana, whom some of you are old enough to remember, and Peyton Manning, who you don't have to be too old to remember. Both of these were professional football players who underwent spine surgery and went back to playing professional football. So these are people who had conditions that we often find in our pain patients, but we're functioning at a very high level after treatment. We see patients who are in bed 23 hours a day with a cervical radiculopathy or lumbar radiculopathy. So again, we need to understand how disabled or how impaired our people are. One thing that's frustrating about this is that it is a time-consuming process to assess functional impairment, and you get nothing for it as far as money goes. As far as I can see, the billing codes and the billing level that you have depends on you getting a history, you're getting a past medical history, review of symptoms, family history, social history, physical examination. Nothing. As far as I can see, unless somebody knows better and can correct me, you get zero for assessing functional impairment. So the problem is this is very relevant to effective care of your patients, but not at all rewarded in our relative value unit system. I think it's worth thinking about sort of impairment as a quantitative issue versus qualitative. By quantitative, I'm saying how severe is the impairment? And you could imagine, and for example, those of you who are familiar with the AMA guides to permanent impairment, there's a conceptual spectrum from 0% impairment, where the person is fully functional, to 100% impairment, where they are basically totally bedbound, totally dependent. So you can, and what I'm going to be talking about is looking at severity of impairment, but as a qualitative issue, the question is, what are the impairments? In other words, if a person is 20% impaired, is that because they can't walk or they can't see? I mean, they're in other words, and if you look more in fine-grained and say, what is it that the person can or can't do, first, I would argue that can help you with a diagnosis. For example, I see a lot of spine patients. I would say it helps me to understand what exactly they can and can't do, because that gives me some insights into what may be going on in their spine. Example, older person with an intolerance of walking, I think of spinal stenosis. Young person who can't stand sitting for any length of time and has trouble managing their shoes and socks, I think of discogenic pain. Also, a more detailed, fine-grained functional analysis can give you targets for treatment. So, for example, if the person is not able to ambulate, what kind of assistance might they need in order to get to the point of independent in ambulation? What if they need help with things like getting on their shoes and socks? Is there a way we can help them? In other words, you can identify treatment goals if you identify specific impairments. I would point out that impairment in pain is a difficult thing. There's this because it's self-defined, and in fact, chronic pain becomes a problem precisely in those instances where damage to the relevant organs is not sufficient to explain why the people are so impaired. And I just give the example as an obvious one. You have a patient with T8 complete paraplegia. That person can't walk, and you can make predictions about what their consequences of that are. They're not going to be able to walk. They're not going to be able to manage bowel and bladder function. But what about a person with low back pain who says, I can't walk? That has a different meaning. I do independent medical exams, and this comes up all the time when there are issues of societal compensation for people who are impaired. And all I can say is that when pain is associated as the cause of impairment, it's very difficult to say how we as a society should relate to that, how we should compensate that, and so on. But again, in pain, the impairment is largely based on there's a thing from 1986, I love the term, the unbearable sensations as people attempt to engage in activities. That's why they are incapacitated, rather than their body simply doesn't work. Okay, domains to assess. I would see two broad areas to assess when we look at functional impairment. One is activities of daily living, and two is work, or let's say more generally major roles, such as a homemaker, but they're major thing that defines their adult roles. For activities of daily living, there are multiple scales that can be used. The Roland-Morris, I know it's Westbury, used a lot in the spine world. There's something called a quick dash that can be used to measure activities of daily living in people with hand dysfunction. We at the Pain Center, thanks to Mark Sullivan sitting next to me, are using the pain tracker. and then gives you pain intensity. It gives you global interference with the extent to which pain interferes with general activity and interferes with enjoyment of life. These scales all tend to intercorrelate well, and in fact, you can simplify down to a 3-item scale called the PEG that correlates well with a lot of the other scales. I right now have a data set that I'm trying to get access to or work with to see how complex the factor structure is in the pain tractor. But I think that what we know now is that these scales tend to intercorrelate highly. They tend to give you a sort of global severity, just how impaired people are. Notice that they are not at all fine-grained. They don't say in what way the person is impaired. In other words, if somebody says 9 over 10, pain interferes, the rating of 9 over 10 for pain interference with general activity, an obvious question would be, well, what activities? And these instruments, none of them really gives that very well. The Roland Morris, in my opinion, actually does a little better because it does go through a wide range of activities that are relevant to spine problems. The Oswestry I don't like as much, but lots of other people prefer it. But again, these are not fine-grained analyses. I think the questions that I like to ask people, I usually start by asking and by the way, let me say, the fact that these are my questions does not make them right. And as you see, the chapter you'll get from Dr. Stoloff is a much more fine-grained thing. You could ask a lot more questions than I do. Basically, we are so often pressed for time that I try to get the biggest bang for the buck, and so these are the questions I ask. I still first want to know about their living situation. If a person is living alone, at least you can infer that they're independent in self-care. But if they're living with others, you can ask them, if your relatives or significant other goes away for the weekend, are you okay? Or do you need help on a daily basis? In our patients, are you able to be up all day? And it's just stunning to me how many of our patients say, I spend most of my day in a recliner or on the couch. And then at least for spine pain patients, back pain patients, I'll ask them about basic activities that often stress the spine: sitting, standing, walking, lifting, putting on shoes and socks. And then I'm going to ask them about pain at night that interferes with sleep. So these again, this is a high-level, sort of very broad analysis, not getting real fine-grained, but at least giving you some idea of how impaired these people are in their daily living. Can you determine how impaired, say, a back pain patient is based on physical exam? I would argue that it's not so easy. Supposing they say they can only sit for 15 minutes, you might observe them when you interview them, but it's not so. There's no exam maneuver that can tell you what a person's sitting tolerance is. You can rely on data from physical therapists because a good physical therapist gets a lot of observational data on a patient. You can, in a contested situation, refer a person for a physical capacities evaluation. This is a very formal capacities evaluation that's usually done by physical therapists over a period of a day or 2 days. So they have the person do activities repeatedly and see what they can consistently do. Unfortunately, the outcomes of the PCEs are not that well correlated with self-reported disability or with the actual resolution, let's say, of an injured worker who's unable to work. It doesn't really help them get back to work. So I would say it is difficult to know how impaired these people are based on physical findings. Often you just have to ask them. So why do all this assessment of impairment in ADLs? I do think you can get diagnostic information, as I said before. You can get a global sense of how severely incapacitated they are. You certainly get some prognosis, at least I believe, that if you see a person who is just incredibly impaired, basically spending virtually all their time down and having their spouse help them with basic self-care, that person's prognosis for treatment that I'm going to offer is very guarded. You also learn something about their support system. Do they have people who help them in various ways? Do they have a caregiver? A lot of our people actually have basically gotten, from the state, they get caregivers for a certain number of hours. And again, if you know in what respects they're impaired, what activity limitations they have, that can help you establish treatment goals. And certainly, like real basic things like walking, I think is such an important thing. If you find your patients impaired in that area, you ought to see is there a way to help them improve in their mobility. Okay, work disability. That's the other big domain that I think of. And maybe an obvious point here, but there is a whole spectrum of work disability from a person who's working full-time and reports no interference from their pain. And I always, try to get some sense, because there will be people who come in, you say, are you working? The answer is yes, but they're on, suspension, or they're on, they've been warned that if they miss any more time from work, they will be fired and so on. So the fact that they're working doesn't mean that they're out of the woods. And obviously at the opposite end, you have people who are 100% disabled from work. So these are questions that I ask. Severity of current work disability. So are you working? Well, that's basic. Okay, full-time or part-time? If they say they're working, are you missing time from work? Because an awful lot of the patients we see, once you begin to drill down a bit, you find that they are threatened on their job. They're missing time. They've been warned by supervisors that they might lose their job. If they're off work, when is it that you were last well enough to work? Obviously, if there's prolonged work disability, that's implies a poor prognosis for return to work. Conversely, if they've been working up until 3 months ago, this to me is the time to pull out all the stops, to involve our vocational rehab counselor, to do everything to help them kind of get back on track. It's worth noting, this is data from 20 years ago from the Department of Labor and Industries here, but I think it's a nice demonstration of a basic situation about work disability. And these are people with Labor and Industries claims. The cohort is defined by the fact that they have started to receive work disability. So 100% of people are work disabled at time zero. And the question is, what is the survival curve? What percentage of these people are still disabled at 1 month, 2 months, and so on? And if you look, I don't know if you have a pointer here, but if you look, okay, let me just try to point. How do I do it? This, no?
Let's put it on the table.
It's a mouse.
It's a mouse? What? Oh, I was thinking of an arrow. We don't have an arrow thing.
Yeah, I think if you move it around on the table.
I don't know. Okay. So the thing is that if you start with people 100% of whom are disabled, and then you go down, look at just 1 month, a lot of people return to work, and then a lot more by the second month. But by the time you get out to about 3 or 4 months, the curve is flattening out. Bottom line is, if people have been disabled from work for an extended period of time, even 6 months, let's say, it's going to be dicey to get them back to work. Practical bottom line is, if people have recently left the workforce, this is the time to pull out all the stops and try to get them back. I think it's important to ask them about the type of work they've done in the past. Was it physically demanding? Simple rule is people with physically demanding jobs, when they get musculoskeletal problems, they're more likely to go off work and not be able to go back. Same thing with entry-level jobs where there are repetitive activities and the person has very little choice over pacing and sequencing of the activities. So again, you want to know the nature of the job and of prior jobs they've had. You want to know something about the type of disability payments that they're getting, and I'll get to that because there's something, in my mind, you can learn a lot by getting an answer to that question. Or more basically, are they getting any disability payments? And then, do you think you can return to work? This probably is the most important thing that a person who's off work can be asked, because it turns out that is highly predictive of whether people do go back to work. So it's very important to get their assessment of what they think they can do. In terms, I think it helps them think about the type of disability that a person is getting, because that brackets what kind of benefits they get and has some implication for the kind of goals you'd have in trying to rehabilitate them. So I'm just going through a few. Private disability programs tend to be very specific. So, for example, a surgeon who had a hand injury might get disability under a private disability program because he could no longer do surgery, even though he could do medical evaluations and any number of other things that involve the skills of a physician, but cannot do surgery. So private disability programs tend to be very specific. Labor and industries. labor and industries is like a large gorilla in the room. People tend to be very threatened when they have L&I claims. I and John Lozier have written a chapter about this, and it's really impressive when you do qualitative research on people who have workers' comp claims, and they feel like they're being watched, they feel like they're being challenged, their integrity, and so on. So it's a highly threatening thing for patients, at least who have sustained and prolonged work claims. There is a lot of paperwork. If you're going to be dealing with L&I, you're going to be dealing with paper. On the other hand, there is good medical coverage, and there are other resources that a lot of other insurers don't provide, such as pain rehabilitation programs, vocational rehabilitation counselors. So L&I has sort of got a mixed bag of good things and bad things. DSHS, there are a variety of different groups within it, which I can never tell really GAU versus GAX and so on. I don't understand them all, but none of them is good. They have a terrible compensation rate. The patients keep telling me they're getting $197 a month from DSHS, and I've heard that enough times to believe that must be a kind of standard pay. I don't know how you live on $197 a month. People who have DSHS will typically have Medicaid insurance. The good news, one good piece about DSHS, it does link with the Division of Vocational Rehabilitation, and those folks, for the people they accept into service, they do a very good job of helping them return to work. Social Security disability, you have to, the medical requirement for SSDI is that you're unable to engage in substantial gainful employment of any kind. You have a work requirement. You have to have, I think it's 10 years. You have to work for 10 years before you're eligible, and you have to have paid into the system. Important to know, if her patient says they've got SSDI, just throw in the towel, because the chances are only 3% that person will ever go back to gainful employment. And the connection in terms of medical coverage, SSDI people get Medicare 2 years after they are awarded the SSDI. The other federal program is supplemental security income. Totally different thing. And again, if your patient says they're receiving SSI, I think just throw in the towel, just give up. You will never succeed, because SSI basically has the same definition as SSDI for what it means to be disabled, but it is for people who do not qualify for SSDI, typically because they haven't worked enough. It's also means tested, meaning they have to be really impoverished to get it. More than 50% of the people on SSI have psychiatric problems or mental retardation, and many of them are children. But if you get a 40-year-old who says, I'm on SSI, you can infer with high confidence that that person has essentially never worked in their adult life. When you're dealing, with disability patients, there are all sorts of complications that arise, and I'm sure you've all dealt with this, but yet it's part of the business of dealing with people who are on disability. Some people, basically want the benefits, want to emphasize their incapacitation. You get attorneys involved. With L&I, in my mind, there's ongoing maneuvering going on. In contrast, by the way, SSDI and SSI are pretty stable. There are what are called continuing disability reviews, but they're really done infrequently. So you don't have as much paperwork, you don't have as much maneuvering with people who are already receiving those benefits. So, summary, how does it help to assess activities of daily living and functional limitations in those areas in your management? I think it does have implications for prognosis. If a person is severely incapacitated in their activities of daily living, it's less likely you're going to make a difference in your care. It can sometimes help in diagnosis if you know specifically what it is that they can and can't do. It allows you to establish specific treatment goals based on the deficits in their ADLs. And again, Dr. Stoloff's chapter describes this in great detail, and I think is very worth reading. And you can also see changes in their activities of daily living as an indicator of treatment efficacy. In other words, if they are less disabled after a month or 3 months of treatment than they were when you started. And what are them in terms of management? How does it help to assess work disability? Again, I think if you know how long the person has been disabled, what kind of disability benefits they're getting, that helps you establish a prognosis for whether they're likely to get better, in my mind. It certainly helps you decide whether return to work is a reasonable goal and how to get that. It may impact the way you write your physical therapy orders. You might want, I put in quotes, sport-specific training, but what I mean is work-specific training. You might want your therapist to really work with the person on activities that they will need as they return to work. If you are thinking about their work disability, you might get involved in interactions with their employer, claims manager, attorney. You might even, if you're very ambitious, become an attending physician for a labor and injuries claim. Okay, that's all I have to say.